let me thank the organizers for allowing me to present a few cases in front of you. So we'll straight away start. I think we are late by half an hour. So this is a 35-year-old healthy man. There's no comorbidity. He fell from a height. He sustained this injury. So the panelists, and after the panelists, everyone in this hall is a panelist. I hope so. So from first.
This looks like a comminuted intra-articular distal radius fracture,
Yes.
and we can see the distal radioulnar joint is also disrupted.
Yes.
So we would like to further assess this with a CT scan.
Yes. Other panelists, please.
It's a comminuted lower end of radius with the DRUA instability. Definitely we need a CT to assess a few things like one, intra-articular extension, the size of the fragments, and about the ulnar styloid I would like to know. And after taking the CT we can plan for the fixation. Definitely the patient requires surgical management.
And now the most important person of the day, VIP of the day, your opinion.
Clinical assessment, especially for median nerve, if you see that proximal fragment there which is completely displaced and jetting on the volar aspect. So clinical assessment for swelling and the skin status and the median nerve apart from the further image.
That's again from the audience.
Sir, any involvement of the scaffold?
So the question is, there is any involvement of the scaphoid?
That's what. You need more views, more imaging, but you should obviously always look at one joint above and one joint below. That is the principle here. The one joint above for me is always radiocarpal. So you should always think of carpus. When you start your surgery, you should always screen and check the carpus. And of course, the one joint below part is the DRUJ, which has been already told. So when you see a distal radius, look at both areas always.
So we'd like to see more cases, so we'll make it a little faster. So this patient went to a local doctor and he did it like this. This was not done by us, but for revision surgery actually he came to us. So this is on the C-arm and this is what the surgeon has done. Now what will happen? Can anybody predict from the panel or from the audience what will happen to this fracture if you continue like this?
So obviously it's not reduced. The radial height has not come back. The inclination has not come back. The DRUJ is still, there's a gap, there's a dorsal displacement, angulation still on the lateral view, it's not even come to neutral position. There's an X fix there. So if you see the amount of distraction there, again I'm not happy. If you see the scaphoid, it's off. Of course the radial height is reduced, but that gap also is not a good thing. So there could be a over distraction which might lead to CRPS and stiffness, but basically the distal radius itself is not reduced.
So in short, this is a day one failure according to you. It's a day one failure. So any other from the audience, Sibyl or Ravindra?
One thing I would like to add. There comes the Graham's criteria. In case of lower end of radius, always we should follow the Graham's criteria. What is Graham's criteria? One is the radial inclination, that is 21 degrees, that you can measure in the C-arm picture. Then of course the level of the radius and ulnar articular surface. Then DRUJ, and in the lateral view, the dorsal inclination. Here the distal end of radius you can appreciate that is angulated dorsally. So this is a malreduction in both plane, AP and lateral.
That's very perfect. But regarding this fixator, this is a disaster in the wrist. You put for any patient, for any wrist fracture, this is going to be a disaster for the patient as well as the surgeon. So this is not a fixator you should do for any of the distal end of radius fracture. Why I say so? Anybody from the audience? What's your opinion, panel? Because this
external fixer has a very few indications.
No, I am talking about this particular fixator, not external fixator. This particular just fixation, which we usually do for CTV. So this is used for wrist. This is mainly a uniplanar fixation, and there is not much possibility of getting a multiplanar reduction, and you have to distract it too much. That's why you see a lot of space over here. Now in that bargain you will distract this also, this area also, and finally you get a cosmetic reduction and you won't get a perfect reduction, and this fixator is a disaster. So as far as possible, we should never use this fixator for any of the wrist fractures. Now, this is the follow-up for the same surgeon. Now, is it uniting or maluniting, or can we continue with this? This is a follow-up after 2 months. First was the initial post-op exam. Can we continue like this, or you will not continue? So this is the situation after 2 months. Now the surgeon removed the implants. All the implants he removed. At 3 months he removed everything together. Now what has happened? What is the situation? Can anybody comment?
It was a non-union and it has displaced,
The
collapsed.
CRPS.
CRBS and osteoporosis.
That is very perfect. It's a non-union. Why this non-union has occurred? Usually, in a lower end of radius fracture, as it was told, it will always malunite with a good function. That is a basic principle. Still, it sometimes holds good, but it will malunite. But it has not gone in for non-union. What could be the reason?
If you see,
That
can you just show the first X-ray? It's just for the PGs here. You should remember, if you put a fixator and think it's ligamentotaxis, it can't be, because if you see the fracture lines there, it's all through the ligaments. So if you know the placement of the ligaments in the distal radius, those fragments are through those. If you see the radial styloid shunt there, and you see the lunate facet, all these are through the ligaments. So ligaments are all, the soft tissue is already damaged. And if you don't reduce and then put a fixator, then this is what happens. Everything collapses. So the fixator won't do any job here because the soft tissues which is supposed to distract are already damaged. So the only thing which is remaining there is the extensor tendons, and the capsule would be damaged here to a certain extent. So there's no way a fixator will work here in any type of fixator. Plus, if you have not reduced, like what has happened there, if it's the fracture itself is not reduced, you can't rely on the fixator. So the moment you remove those K wires and the fixator, that last picture is bound to happen.
so this is the current situation. Now will you proceed?
So one question, if suppose only KY was put and there was no X-fix, would this have united? Only KY, 5 KYs and without X-fix, what is your opinion? Would have united or
I mean,
malunited?
if you have not reduced it, it would have
With the
malunited.
same reduction. With the same reduction what you see here,
Yeah.
should have it have united? Is that just the culprit? That's what I'm asking.
That's right. So, yes, I mean, we expect it to unite. A distal radius, we expect to unite 99% of the times. Okay. Here also, I won't say it as a non-union right now. I would probably put it, it's because of course there is some amount of contact there. But otherwise, if you go in now inside, you will have a lot of fibrous tissue, and it's like a nascent kind of a thing. You can easily pull it back.
Yeah.
It's not become an established non-union right now.
So clinically there is abnormal movement here, but since it's a distalmost fracture, you cannot appreciate whether it's in the wrist or the fracture site. So what will you do now?
So how's the wrist movement and function of the hand? Is it still
Luckily it is not infected. Yes, full movements of the MCP, it is not stiff. Usually what happens in this fracture is when you distract it, it results in stiffness of the MCP. And it's a disaster for the patient. The movements will never come back. But luckily for this patient, MCP movement is good, wrist movement is good, and he can pronate and supinate. It is not very painful. He has got good movements, but the problem is every time he does, there is an instability here. So that's the problem. So we wanted to look at a CT now. Previously CT was not done by the first surgeon. So when we clinically examined, we thought it is a non-union, as it was rightly pointed out by the panelists, already pointed out it could be a non-union. And CT wise, it is a frank non-union. There is no union at all. So you go through several films and you examine it, and finally it is a frank non-union. There is no union at all. It is not a malunion or a partial union or a delayed union, nothing like that. It is a pseudarthrosis-like situation. This is after 8 months. Now he removed the plaster, he walked around several times to several doctors, and then he is not able to work because of an unstable wrist. So after 9 months, 8 to 9 months, he came back. At that time we took CT. So you can see the CT picture. It's a frank non-union. There is no bony contact anywhere, and it has not united. That's why, as Professor Anilbert told, 99% it should have united, but in this case it has not united. The culprit is the fixation. So at least from this case you should learn that this is a fixator which you should never use for fracture lower end of radius. Now after that we did a salvage procedure, we did bone grafting, we did a plating. This is on the CM picture, and as we did some shortening we accepted, and then that's why we did a length reduction on the ulna, and still the patient has got good function. Now this patient has got full wrist movement. Previously also it was like that. After removing the implant also he had a full pronation supination, he had a wrist movement, he had MCT, but only problem was he was not able to work because of the instability. So the fracture union purpose we did liberal grafting with plating, and we did ulnar shortening. We did an ulnar shortening little above because there was a huge incision at the lower end of radius.
So was there a DRUJ instability?
DRUJ instability we wanted to treat, but this patient has got good pronation supination, painless. So it was accepted. We knew that DRUJ, but it was not painful. Had full movement like this. So we accepted.
Okay, and so can we go without ulnar shortening in this case? It's 2 months, or it's
No,
always.
if you are doing a radial shortening, you have to do ulnar shortening. If you can get back that those components back and then fix it, then no. But I think they went primarily for the radial shortening. The proximal segment was shortened and the distal port was put back. That's what I'm sure they would have done. But if it was slightly early, maybe you can still go ahead, take down the fibrous tissue and still come back and get the radial height back. Possible. You will have to struggle, but then you'll have, yesterday I did a live surgery in Mumbai, same case where the proximal fragment, they are sitting like this. So you have additions with the tendons here, you have additions between this fragment and this fragment, you have additions of the dorsal distal fragment with the extensor tendons and the periosteum and all. So you have to take down 3 layers, then it will start moving. Okay, you can use a laminar spreader, small laminar spreader or any of this, and then push it, and with some traction and the soft tissues generally yield, then you can get it back. So that time you don't have to do the ulnar shortening, but otherwise you'll have to do this to get the DRUJ back.
So any other point to be clarified in this case? If you are quick enough, we can see more cases.
May I ask you one doubt, sir? Regarding the ulnar shortening, what is the accurate site of ulnar osteotomy?
SBT is a lower level, but this patient had a huge incision below and he had a lot of bone grafting. So soft tissue cluster was a little difficult in the lower part.
So otherwise you would have
the lower part, lowermost part, wherever you can do. 3 screws distally, 3 screws proximally at distal most.
Don't take the ulnar shortening lightly because non-unions happen very commonly. Plus you should, as Gopi is telling, you should have the 3 screws distally. So you need to place it in such a way where we can get the fixation good. Otherwise it always invariably goes for problems. So ulnar shortening is always a very dicey procedure. Not to take it lightly about that.
Previously people used to do Darac's procedure, no longer it is done because of so many problems. I am not going into the details. So Darac's procedure is the one you should never do, because it leads to proximal carpal migration, it will lead to CRPS, so many problems. So what about your opinions on Darac's? Any modern orthopedic practice?
I mean, for me, Darac's and Kapanji is only if there is arthritis, nothing else, not in any acute situations. So only if there is an arthritis of the ulnocarpal joint, I do Darac's. If there is a distal radio ulnar joint, I would do Kapanjis. That also I am very clear. So if there is a ulnar head which has gone into damage, previous old ulnar head fractures, gone into arthritis, and there's ulnocarpal arthritis, I would do Darac's. If there's a radio ulnar joint arthritis, not acute situations, I would do Kapanjis. So that I'm very clear about that.
But in ulnar osteotomy, do a transverse osteotomy or an oblique or something instead?
So all are described. So it all depends on how good your fixation is. So you need to have a good locking plate, but at the same time you should not have any gap. You should reduce the fracture, not rely on the plate for any reduction. In that way, even a DCB would be better actually, because we'll get a good compression. Yeah.
So any other point to be clarified in this case? Shall we move to next case? Yes. This is a 55-year-old man had a road traffic accident. His lorry in one of the airpin curves, it turned upside down in Ghat roads in the midnight. He came to our hospital like this. So how to proceed? I think the fragment specific classification and treatment has been already described, but I was not there, sorry for that. So how will you proceed?
So again, it's the most important component is the volar lunate facet, and if you see on the lateral view, that's called the teardrop, which is whitened. So So AP diameter is widened, which means that the lunate facet fragment is the one which is the keystone there, which has to be come back. Of course, again get a CT and see the fragments nicely, all the fragments, part of the fragments, and then take a decision on that.
Other panelists, please.
The most important part it is communicated, that is articulation of the lunate to the radius, both on the volar and dorsal side, I believe. When you look onto the lateral view, you can appreciate a fragment, it is displaced dorsally. And on the ulnar styloid, there is a suspicious fracture. DRUJ is unstable. Definitely surgical fixation. And before proceeding, better we have to take a CT scan.
But this is an open fracture. It's not a closed fracture. This ulna we can see outside. There is a wound over there, and here is a wound. And this was, but still it was not very much contaminated. It can be grade 1 or grade 2 like that. So, will it affect your management?
After the debridement, if we have a gut feel that it is clean,
Yeah,
and over the antibiotic
we'll
allergy, we can
take
proceed
it
with
as
the
a closed fracture.
Pardon?
We will consider it as a closed fracture.
Closed fracture, and we can proceed with the definitive fixation.
So these are the other X-rays, and this is CT. As it must have been described in a that is quite usual because it is known as a dorsal plate fracture. So if you look at the fragment specific classification by Leslie, you will know that there are 5 fragments you should look for. One is a radial styloid fracture, the other is a volar vein, then it's a impaction fracture of the lunate, third is the dorsal ulnar fragment and the dorsal plate. So this is a dorsal plate fracture as you described, and it is mainly due to the fracture configuration itself. So this is the situation. So you talk about any classification, but for the time being for this case, we will talk about the column based classification, the fragment specific classification, so that it will help you in treatment. So as per column based, can you identify those 5 fragments here or in the CT?
I would rely a lot on the axial views. Yeah. So this is what gives you, if you see the third row there, that is what gives you all the second and third row, the number 3, 4, 5, 6 figures is where you will decide on your approach, your management and everything. So that tells you the whole story. So if you see the central portion, it's called as a free floating intraarticular fragments.
Can you show us that fragments you are going to look for? Okay, come here. This is the point.
So it starts from here. At this point, so this is what I was telling even for the previous one, where your ligaments are attached all the way here. So you have the radius capitate ligament here. You have the lunate, the radial lunate ligaments here. You have the dorsal ligaments here at this point. So this is where the fragments come off when there is a fracture. So it's always the soft tissues which take the predominant things. So when you see something like this, so you can start from one corner, you can go to the other way depending on how you want to analyze. So you will see this is the sigmoid notch now, and this is the lunate facet fragments here at this point. And your approach is based on how much of where is the fracture line here. So this is where the carpus moves. If you see the sagittal of this. So if this is the major fragment here, and this is a smaller fragment here, my approach would be volar, right? So I would use a volar plate here. If this was 50-50, I would still use volar because I'll be able to catch the dorsal fragments. But if this fragment was the major one, probably I would go dorsal plate. Okay, so that is the first part of the decision making. Second is what happens to the radial styloid fragment. How big is the radial styloid fragment which you require? Do you require an additional lateral plate, or your volar plate would do the work of holding that fragment? That is the thing. Third, you look at these fragments, the inside ones here, and a lot of times you do what's called the intrafocal reduction, where you open the fracture site, push this fragment up. Those are the free floating fragments, and they need to be pushed up before you put the plate. Okay, so this is the Malone's part of the classification, and what Gopi was telling was the columnar part. So both has to be added for this fracture for this patient.
So if the dorsal fragment is very small, we'll go dorsally or volar?
No, volar.
Volar. But from volar, can you catch the dorsal fragment?
Yes.
Is it possible?
And don't have to, if you saw the flake thing, you don't have to bother about it. They'll all heal.
Okay.
Yeah.
Do you take off the capsule to see the volar rim, or
No.
you go through the fragments?
Through the fracture, intrafocal. So you go through the fracture and then lift this. So when you lift this again, people will ask, would you put a graft, like a tibial condyle? Would you put a graft? No, you don't, because you push the subchondral bone along with the articular surface. So as you're pushing it, right, you use a trithovan or any of those things, there's a lot of cancellous bone in the distal part, right? You take that subchondral bone and push the fragment up, it will stay nicely. You can put a provisional K-wire at that point of time, a raft wire, and hold it there. And that will give you the good, nice reduction of the central fragment. SEM won't show that.
The dorsal ulnar,
Visualize
sir.
the distal articular surface.
Sorry?
Do you visualize the distal articular surface, or is it an indirect?
It's indirect. Yeah.
So dorsal ulnar column fragment, the small one. You told you go volar wards, volar plating.
Dorsal ulnar, if it's a small fragment, I would go volar. Yes.
Volar. Okay. So to hold that, to have a purchase on that fragment, you need to cross the dorsal surface. Number one. Number two, to put a screw there, especially in a very distal fragment, you have to pull the plate far distant to the watershed area.
Correct.
Right? So that can produce two problems. One is the extensor tendon irritation and the flexor tendon irritation. So is it not wise to go dorsalwards and fix it dorsally rather than going from the sun?
So if it is a very small fragment not occupying the majority of the sigmoid notch part and also the radial articulation.
No, probably that you can leave it like that.
So that's
right?
what I'm telling. Yeah. So we don't have to go to try to catch this from the dorsal side. The majority of it can be, because you should not be looking only at this. You should be looking at all other fragments.
Yeah.
And your volar, whichever plate should span everything. Not additional plates, too many plates here. So my volar plate would do all this work with the intrafocal reduction except this. Right?
Yeah.
Then I don't have to worry about the dorsal plate.
No, suppose that has got a stability on the distal radial ulnar joint. Is it not wise to put a plate
So
dorsally?
this won't have stability based on your cut here. Right? If it is more than 50%, then it will have a bearing on stability, not otherwise. And crossing watershed line is not a problem as long as you have a variable angle rim plate. You can go all the way up there. That's
Won't it produce a flexor tendon irritation, flexor pollicis longus rupture?
In a rim plate, it won't. Because it's a low profile plate, your screws are directed proximally, not towards the joint. Plus, you should see that the low profile plate, the rim plate is not, very proud. So, all those things have to be taken in. So, the plate you select is very important for these kind of fractures, when it's very distal. If you don't have that plate, you are in trouble at that point of time. Yeah. Then you have to tell the patient early implant removal.
So they are saying that time is up, but we have few more interesting cases to show. We will just go quickly so that we can see more cases. So this is a fracture which can be classically described based on Mellon's or collar-based classification, and the approach is what we should look at. As it is rightly pointed out by Professor Anil, but volar approach is good. But for where you approach between the radial artery and FCR, or between the FCR, medial to FCR or lateral to FCR. So it depends on the fragment you are going to address. So if you have a fragment which is on the near the sigmoid notch, which cannot be reduced by the incision or the approach between the radial artery and FCR, you could go medial to FCR also. But the problem with going through the medial side is median nerve. So you have to do a prophylactic carpal tunnel decompression sometimes, but sometimes you may be able to approach through between the radial artery and the FCR. Now this is what has been done. So this immediate post-op, we could get some hold of the ulnar side of the fragment, but this was an open fracture, so we did not go for multiple incision or multiple plates. Then finally we removed it, the K-wires, and then this is the current situation. So
the only thing is there is have at least 2 screws into that lunate facet fragment.
Yeah,
whichever plate you put, get 2 screws there. That is the only way it gives a stability. You can have additional K wires also, no worry, as in it's a raft wire, but you can at least 2 screws should go into that. Whether you use dorsal plate, volar plate, whichever.
That is perfect. This is done through volar approach. We did not go through the medial side of the FCR. We did not put 3 plates because it's an open fracture. 3 incisions we did not put, only 1 incision we managed, it's all plate.
So when we are combining K-wire, can we keep it? Is it necessary to keep K-wire inside
Because
the ring
we are not
or
getting,
outside?
as I told, we are not getting 2 screws into the medial fragment, so additional K-wire was put.
I'm asking, is it necessary to bury the K-wire when you are combining it with the plate? Because the chance of infection. I heard that.
No, you'll be putting a plaster, right?
Yeah, plaster is there, so there's no harm. You can keep the K-wire outside.
So this is another lady. Can we go to next case?
Before that, I would like to ask one question. Suppose if you are not able to put two screws in that fragment, would it be possible to put a KY, trans-articular DRUJ, and whether it will be beneficial?
Don't have to put transarticular, you can still put a raft wire and hold it there.
Just parallel to the wrist joint you can put.
Parallel to just below subchondral, you can put K wire. You can put 2 K wires, spread it out and hold it there.
Do you bury it or you keep it outside?
I keep it outside.
After 3 weeks you can put it in.
Yeah.
This is a lady who came after 2 years of her original trauma to us. Now this was the first X-ray. He went to a surgeon. This was the first X-ray. He first managed it with POP. He was not happy with that. So what he did was he did this. Are you happy with this fixation? This is 2 years before. After 2 years, she came back to us for a revision surgery. So, but she could bring all these X-rays. Are you happy with this fixation or anything else has to be done?
6 weeks.
This is at 6 weeks. 2 years back, but at 6 weeks of original injury.
Okay.
Happy? Yes. Can be accepted?
We don't have a choice if she comes at 6 weeks with this.
No, 6 weeks she did not come to us. 6 weeks she went to the original surgeon, he accepted it. He came back to us after 2 years only.
2 years only, okay. Yeah.
Previous X-ray, is it a Barton or something?
The thing is that this distal fragment is big enough for another kind of fixation, and this is against the principle.
No,
Apart
is this radial tilt, radial height?
that looks
everything
okay.
is
but that fragment is big enough to hold other kind of fixation.
No, question is, can you accept this at 6 weeks?
At this point in time, I would accept
Yeah.
it just looking at the X-ray. Yes.
Accept.
Yes.
Yes, accepted. Now this is the follow-up X-rays, but she did not have any pronation supination. It was fixed like this. Not even a single degree of pronation supination. It was and was fixed. That was her problem. She wanted to do some jobs like this. So after 2 years, this was
No, the
situation.
story would have been that the moment the fixator would be removed, it would have collapsed and the DRUJ would have subluxed.
Yeah.
That would have happened at that.
That could have happened, and you can see some shortening over here also. So there is a even at 2 years she is not happy because she has got a. So we did it like this. As professor told, you do only for arthritis, but we did a salvage procedure. She wanted pronation supination. So she got it, pronation supination. We did not do anything for the radius. Can we go to next case?
One thing, the proximal fragment, do you do anything to prevent the subluxation of the proximal fragment of the ulna?
It was not done.
Always we do a FCU sling.
FCU?
Sling.
Sling.
So FCU sling, distally based this one, take it out and then go through the stump and suture it back. So the FCU is pulling it down. We do it for Darax also now.
Okay.
Same thing we do for Darax also. Yeah.
So this is another case.
One more point. Do you need to remove that Sauvage-Capaggi screw?
Yeah, we removed it. But you would have seen that one picture. Unfortunately, she had a myositis here. It's reformed. So again, we removed that. We removed that bony mass also, and she got full movement. Another case. This any opinion from anybody in the audience or panel? Again, a similar case. This patient is 35 years old, male. 35 years old male, no comorbidity. That's this is correct.
Axial section.
Axial.
So this is where the volar cortex is completely intact. There's a lot of combination in the dorsal aspect. So probably there's an indication for a dorsal plating here compared to the one we saw earlier. So if you see that 1, 2, 3, 5, 6 and 8 photo there, so that's what I was trying to tell, where that fragments have separated out. So you have the radial styloid big chunk, you have right in the middle, you have the volar fragment, dorsal fragment, but if you look at the combination of dorsal fragment is much more than the volar side. So this is the way you can decide whether you want to go as a dorsal plating as a primary thing.
As it was rightly pointed out, dorsal plating always has got its own problems. In a thin patient, if you don't have a special dorsal plate, you are going to have all the problems of extensor tendon, impingement, extensor tendon rupture. So, can you go volarly and capture that fragment?
I mean, you can, but if you see the volar cortex, it looks intact, right? So I would be addressing more on the dorsal aspect. Dorsal plating, of course, with the low profile plates, what we have, I don't think it's an issue anymore.
Yeah, if you have a special plate, then only attempt dorsal plating. With the usual plate, you should not attempt dorsal plate. These are the other cross-sectional views. This is what we did. We could capture it from the volar side and did that. Can we go to other case?
Is there a articular deficit or something?
Articular penetration is not there. We verified it several times. You can see the APV.
So in those cases, can we combine it with the dorsal cable?
Yes.
Suppose you are going volarly and you are not able to cast because there is so much dorsal combination. Is it advisable to put a dorsal cable?
See, the articular surface, as far as it restored, I don't think we should worry about the combination of the dorsal fragment there, the distalmost part, they all heal nicely. So
there is no need to
try to catch each of them. So even with that, we're asking about the length of the screws, right? I would still put it unicortical, as in put 75%. I won't go and catch the opposite fragment. That will definitely lead to more problems with extensor tendons. So even in that case, I would just keep it like what we do routinely.
You need not go up to the dorsal cortex. 75% is adequate.
Either you put a plate or you don't do anything.
Okay.
This is another patient, 38 years old male, is a very poor patient. He was not willing for CT. So without CT, we were forced to manage this case. So this is X-ray. Without CT, are you 38 years old male? He fell down from a height, but he is very poor. So we did not take a CT for this. This is X-ray.
Reduction X-ray is there? Close reduction X-ray?
No, we did like this. We could
Aft cable.
Yeah, we could arrange some implants from our own side, and we did it like this. But unfortunately, CT is not there. We did not take
Why
it.
X-fix, Gopi?
Because we did not see the CT. We did not see the CT. We did not run the combination. So we wanted to be double. So we removed it very early. We did not give any distraction.
And I think you have modified it. You have make a bend at the wrist in the other picture.
So this is not just.
This is not just this static
Regular AO kind of a fix.
Yeah, because there is.
But if you see the X-ray also, the articular surface looks decent. If you see the previous one, yeah, you can see the articular surface. It's nice. There's no much of combination there. It's more of metaphyseal thing. Both in the lateral view also you can make out that the lunate is sitting nicely there. You don't have to worry about much. There could be maybe one line going between the scaphoid and lunate facet there at the most.
Now,
Is there a DRUJ? Is there a DRUJ problem from the X-ray?
No, once you get the height back, it will fall back. I don't think it's. That's why I said that part is still intact. So not have to worry about. At the most, maybe we would have taken a traction view during the interop.
The only question for this case: are you justified in doing this case without CT? Without CT, justified. Okay.
Every intraarticular fracture deserves a CT. That's
So
what
whether
we've been taught.
pre-reduction or post-reduction?
No, always post-reduction. Always post-reduction. So, the instructions are very clear for the residents. Do as much close reduction as possible when the patient comes with mild sedation. If it's not contraindicated, patients don't have any head injury and all those things, then only get the CT done. Never X-ray and CT together. Never. So you want to see the fragments where they fall back. If you just do X-ray and CT pre-reduction, this is useless. The CT is useless. No, we don't. We've not at all. I mean, not been using the X-fix for it. We'll just do a debridement and still. Yeah, just a slab and then reduce as much as possible. Take a CT.
That helps in planning better because pre-reduction it will look so alarming and disturbing. But at the moment you reduce it, it helps in planning.
So the difference between other fixator is that here you are not giving any distraction, and there is some three-dimensional alignment you can get. So it's a little different type of fixation. I was talking against just fixator, not about this external fixator. So it was removed, and then this was the final fixator. But she wanted to remove the implant. we put the implant on our side, and then she insisted on removing the implant. Usually we don't remove the implants. This patient insisted that implant had to be removed. So we removed, and she is asymptomatic, but anything has to be done. We have not done anything for this, but what's your advice? Will you leave it like that, or you want to graft it?
At the time of implant removal, how was it? Because United solid.
Solid stable. She is asymptomatic.
Then I think we should just
She
leave.
is asymptomatic. This is the lateral.
But then post implant removal, you need to immobilize for some time.
Yeah, we
not
gave
just
a slap.
leave
We
her
gave a
and-
slap for some time. And
Yeah, otherwise, through those lines and plus that gap there, it's always a problem. So you need to be careful, follow her up at least for 6 months so that she doesn't again have a fall. And we have had problems with that. When patients are insisted for implant removal and done, and then they come back with a refracture, you feel bad. And especially with this gap, you should be telling her that she has to be careful with the weights.
Yeah. Now the question for another question for this case is implant removal warranted or is needed, or you will say never, it can be never removed. What is your opinion? It should be removed, should be kept like that, or if you wish you can remove.
Better be kept like that. There are certain definite indications for the implant removal, and like infection or any screw protrusion.
There was no infection yet.
Then we can leave it alone. Why we need not want to operate that patient. Moreover, that patient was so poor to afford another surgery.
That's a great opinion. You need not remove the implant. You just keep it like that. And if somebody is off track and wants to get it removed, then you'll have to remove it. Get it removed. Okay, can we go to next case? So this is a scaphoid. Should I show scaphoid? Because I already described it. This is after 10 months of injury.
Was he managed with some immobilization?
Yeah, it was treated by initial surgeon with a scaphoid cast for 3 months. Then at 9 months, he had some pain over this area, and he could not dorsiflex. When he does push-up or some activities where dorsiflexion is needed, there is pain like that, he came.
Lateral view. Yeah. So 10 months, obviously, I mean, X-ray wise at least I don't see any change in the proximal pole density. I would still just treat it as a non-union. I would not ask for an MRI, really.
But as you said, he came with MRI.
Yeah, they come with MRI. And you'll also get the report that it is AVN also.
Yes.
Yes.
Rarely we get CT. People always come with MRI for scaphoid. Nobody comes with CT. No, that should be.
I mean, for a non-union, you don't really require a CT because a lot of times you would see the gap and you will see the displacement and everything.
For deformity, do we need to have a CT, sir?
No, that's why I asked for the lateral X-ray for the interscaphoid angle, the humpback deformity. And you see some amount of flexion is there of the distal pole. So there will be a humpback deformity here. And yeah, for me it's basically curate out all the fibrous tissue, pack it with cancerous graft and put a screw and
Yes, that's
molar approach.
pull approach. This is a dorsal approach.
It's a dorsal lateral view.
Yeah.
And again, we packed the graft. Packed with graft from the distal end of radius.
Okay.
So AP view, just show me the AP view.
Last case.
Sir, I AP view not just. So why does the scaphoid look like that in this AP view?
This is lateral view.
No, AP view, just show me this one.
Yeah.
AP. Yeah.
So if you see, Gopi, can you show the lateral? So if you see the lateral view and you see the lunate, not very clear, some amount of DC is there, which means the amount of scaphoid length is not probably achieved completely. So that's why the AP view will still look, it's like kind of flexed.
Okay.
So when you are fixing the scaphoid, always keep looking at the lateral view and looking what's happening to the lunate. So we usually, for non-unions, we always take the opposite side X-ray, measure the length and keep it ready. And intra-op, we have to achieve the length of the scaphoid. The lunate has to come and sit neutral, then only that is the correct position. Otherwise, you're reducing the length of the scaphoid and cause instability.
See, lunate is not coming in because can you put a K-wire and just joystick the lunate?
No, your basic thing should be to get the length of the scaphoid back.
Okay.
That is very important. So you have to distract, open up the humpback and hold
Till
it.
you get the lunate in the correct neutral.
It will come. It will always come back. No point in forcing lunate to neutral and then trying and keeping the scaphoid length less. No, it should be the other.
Always see
way.
the lateral view
Yes.
before you put the bar.
This is a small child, 8 or 9 years old. Then she had this fracture like this. So this is a simplest of all cases. I just put it for completion sake. We did it like this, and finally it united. The patient is asymptomatic now. Anything else to be done? For a pediatric case is enough. Okay. So
Are you happy
we
with
got
the
the
scaffold
certificate.
in its space? Is it normal?
Sir, putting KVR in the distal part of the ulna, will it produce some problem? Because we had some cases where it produces growth arrest in pediatric
No,
age group.
here there's no.
No, here there is no ulna.
Okay.
It's okay. For some cases there is lower ulna fracture also.
Yeah.
People put KVR layer. I had 2 cases where the ulna growth arrest happened. The ulna doesn't
It depends on the thickness of the wire and everything.
So how much thickness you advise?
Just less than. I mean, should be less than definitely 1.5. It can't be like beyond that. So 1 mm, 1.2 mm, just enough to hold that, and obviously not passing through that. If you can avoid the physis, fine. But if you have to go, just a single pass of that 1 mm or 1.2 mm wire should be enough. Multiple things. Again, the heat, everything. A lot of things are there.
Okay, thank you.
How many wires did you use? Single wire or cross wires?
No, ulna single wire, but it went through the physis of the ulna. And the child came after 2 or 3 years. There was growth arrest of the ulna.
Usually it won't happen.
2 cases, that's all.
I think that was a great session. Special thanks to the panelists, especially Professor Anil Bhatt was traveled from a long place to teach us. Please give him a big hand and a standing ovation, please, to Dr. Anil Bhatt.
Now I would like to invite Dr. Anil Bhatt sir to give away the memento to our speaker Dr. Gopinathan sir. Please sir.